Today session being the first part, and we have a very eminent faculty, Dr. Mary Abraham, joining us to walk us through the session. For faculty introduction and further session facilitation, I invite Dr. Sridevi ma'am over. Ma'am, over to you.
Thank you everyone once again. I hope you had a good session on the introduction to pain, where you might have heard about pathophysiology and types and assessment a little bit. And today we move on to the management part. Today we'll be covering step 1 and 2 and adjuvants. There are so many points to learn from this session because it's a very vast topic. We generally take half a day or a whole day to cover this. So ma'am will try her best to cover that in the session today. And we have Dr. Mary with us joining from Delhi. She's a neuroanesthesiologist and pain and palliative care physician. She has a special interest in pain management, and she has written a book on conquering pain in 2019. And she uses a lot of pharmacological and non-pharmacological techniques to manage pain in her own setting. And she has received Lifetime Achievement Award by the Delhi Neurological Association for her contribution in neurosciences in Feb 2017. Now you will understand how she becomes the most eligible person to deliver today's session. Thank you, ma'am, for joining us again for today's session.
Thank you, Sridevi, and Sridevi for the generous introduction that you gave me. And thank you so much. And thank you, Shripriya, for organizing it. And am I audible?
Yes, ma'am.
Audible? Okay. So I would like to share my screen. Okay. If you can allow me share screen.
Access is already there, ma'am.
Okay. So I'll just open my presentation. So without much ado, let me get on with my presentation. It could be a little long. I'll try to finish it in 45 minutes. So the broad outline of my talk would be on the basics of the WHO analgesic ladder. And I will discuss step 1 and step 2 drugs of this ladder, along with the adjuvant drugs and the drugs that are used for neuropathic pain. So the WHO ladder was devised based on the recommendations of a group of international experts to deal with pain, and specifically cancer pain. And this was done way back in 1986. It's nearly 30 years plus, but it has stood the test of time. And even today, we are following the WHO analgesic ladder. There could be a few modifications here and there, but the basic we are implementing in our day-to-day practice. And it is so popular that it has been translated into 22 languages and served as a catalyst for treating cancer pain worldwide. Now, it is a stepwise approach to treat cancer pain, depending on the severity or the intensity of pain. Now, prior to this, prior to 80s, people were dying with unnecessary pain for two reasons. First of all, there was a lot of drug regulations associated with the use of opioids. It was, there were a lot of, the bureaucratic thing was quite a lot. People had to have, permission, even to prescribe the drug, to store the drug and dispense the drug. So there was a lot of drug regulations, even for people to get access to opioids was very difficult because of these regulations. And also there was a stigma associated with prescribing and taking opioids. People were worried that they will be termed drug addicts, and the relatives were scared that their loved one will become addicted to morphine. And so there was a lot of stigma because of the use and misuse of opioids. So this stigma also prevented the use of strong opioids in the treatment of pain. But when this stepladder was devised by the WHO, it actually legitimized the use of opioids, because the World Health Organization is telling that it is used as step 3 drug. So they have actually legitimized the use of opioids. So which gave it a lot of thrust for it to being used more and more. Now I'll start with a case scenario. A 35-year-old father of 2 young kids He had squamous cell carcinoma of the right upper lobe. The pain he had was a gnawing pain in the right shoulder, along with a burning and tingling sensation in the right arm. He was unable to sleep. The pain score was a numerical rating score, NRS of 4 during the day and 6 at night. So I'll come back to this case scenario once we have gone through the presentation. So before applying the ladder, we need to make an assessment of pain, and which must have been dealt with in the earlier class. Okay, so the pain has to be assessed, specifically the severity of pain or the intensity of pain, because that is how you are going to apply the ladder. So once you know the intensity of pain, you should also know whether this pain is nociceptive or neuropathic, or is it a combination of the two. Again, I think this would have been taught to you that nociceptive is pain due to tissue injury, and neuropathic pain is because of a lesion in the nervous system, whether it's a peripheral or the central nervous system. So, or sometimes it could be a mix. Now, that is also important, because when you're applying the ladder, you need to know whether you need to give an adjuvant drug or what or not. So in the ladder, you have, it's basically a 3-step ladder. Step 1 is for mild pain, where the NRS score is less than 4 or maximum 5. And in this, where the pain is of that intensity, you use a non-opioid analgesic with or without an adjuvant. If the pain is not getting controlled with this drug, or if the NRS is more than 5, say 5 to 7, then you characterize it as moderate pain. The earlier one was mild pain, now it is moderate pain, in which case you add a weak opioid to the existing regime of a non-opioid analgesic with or without an adjuvant. Sometimes it's not even controlled with this, or if the NRS score is more than 7, then you may have to go to the 3rd step of the ladder, that is a severe pain, where you give a strong opioid instead of a weak opioid. So we give a strong opioid with or without a non-opioid drug, and with or without a adjuvant. So based on this kind of gradation, you can treat up to 71 to 76% of cancer pain. They can get satisfactory relief just by applying the 3-step analgesic ladder. Now, what are the salient features of the ladder? 3 things you must take home with you is that the drugs are given by mouth, by the ladder, by the cloth. Okay. Now, by mouth, this oral route is a standard route, even for the step 3 drugs or the strong opioids. And because of it, it's a huge advantage, because these drugs can be given at home. You don't have to be in hospital to receive the strong opioids also. So it can be given by the visiting nurse, or it can be given by the relative. So it is basically domiciliary use. It can be very suitable for domiciliary use. Of course, you can give it in severe pain, you can give it by other routes, but this WHO analgesic ladder tells that you can give it orally. The second important thing is it's by the ladder. That means you normally start with step 1, and according to the severity of pain, you can move up the ladder. But occasionally, where the pain is very severe, you can start with step 3 drugs. But in the normal course of events, you just start with step 1 and then move upwards, step 2 or step 3. The third important thing is it's given by the clock. By the clock means it depends upon the duration of action of that particular analgesic that you're giving. It is not given on a PRN basis, like when the pain comes, then you take a tablet. That leads to a lot of peaks and valleys in the pain management. You want to achieve a continuous score of around 3 or 4 or less. Okay. So, but by giving it on PRN basis, you are defeating this purpose, and you are causing the breakthrough pain to occur. And it is more difficult to control once the pain has come back in its full intensity. It's more difficult to bring it down. So you have to give it by the clock, which means, for example, a morphine, immediate release morphine, its duration of action or the half-life of the drug is only 4 hours. That means every 4 hours, you have to give the next dose of morphine. So you have to explain this very specifically to the patients, that you have to give the first dose at 6 o'clock, then at 10 o'clock and 2 o'clock. You have to put a timetable for that patient. And if it's being given along with paracetamol, then you must say that paracetamol is to be given every 6 hours. So each drug has its own duration of action. So the administration is depending upon that. Another very important characteristic is that it is individualized to the patient. That means the right dose of the analgesic is the one that causes good relief of pain for 24 hours. So it means that in one patient, you can get that kind of relief with, say, 60 milligram morphine. In another patient, the relief is obtained only with, say, 300 mg morphine. But 300 mg morphine is a right dose for that second patient, and 60 mg is a right dose for. So it has to be very much individualized to the patient. Also tell them that what happens that in between the dose, if you get pain, what do you do? That is breakthrough pain. How do you treat it? All these have to be specifically explained to the patient. The other thing is there is adjuvant drug at every step of the ladder. So that is to treat specific types of pain and also to decrease the undesirable side effects of some of the analgesics. And attention to detail is very important, because whatever drug you're giving has to be given based on the patient's age, whether it's a baby or whether it's an elderly person, or the body weight of the patient, what are the comorbidities the patient has, and also you have to monitor the side effects also of the drugs. So that explain to the patient that if such and such a side effect occurs, then you have to inform of whatever action needs to be taken. So these are the salient features of the WHO analgesic ladder. So it has got a lot of advantages. That is why it is we are using it even today, 30 years after its inception. First is it's a very simple tool, easily understood. It's validated tool. That means by using the ladder, you can actually get effective pain relief. So it has been found to be effective, and it's also very cost effective. Drugs like morphine and methadone are very, very inexpensive drugs. So it's cost effective. It can be implemented across the world, even in underdeveloped countries, well suited for home care, and it can also be given in acute pain. For example, pain due to a fracture or due to post-operative pain, and even in chronic non-cancer pain. Now, some modifications of the WHO analgesic ladder are there. Sometimes you can omit step 2 and directly jump from step 1 to step 3. The pain is very severe. Or you can add a 4th step to the ladder that is used for treating intractable pain, which is not responding to the oral opioids. So this was devised somewhere in 2000, in which the 4th step of the ladder was for those segment of patients, say about 10 to 15% of patients who do not respond to the step 3 drugs or the strong opioid drugs. So what are the modalities that we use in the step 4? You can give various nerve blocks, you can give epidurals, you can use a patient-controlled analgesia pump, you can give a neurolytic block like a celiac plexus block or a superior hypogastric block, or you can use spinal stimulators like dorsal cord stimulation. You can use intrathecal opioids. So there are a lot of things, and even more complicated and sophisticated advanced therapies are also available. So they are used in those patients who have intractable pain, who are not responding to the conventional WHO ladder. Now let's discuss step 1 drugs. These are used to treat mild to moderate pain. They include paracetamol or acetaminophen as it's called, and also non-steroidal anti-inflammatory drugs, and they can be combined with an adjuvant drug. So paracetamol is a term we use in India. In America, it is acetaminophen. It has got a predominant central action. That means it's acting on the central nervous system. It inhibits the enzyme cyclooxygenase or COX. It has no effect on peripheral COX. And because of which, the side effects also are less. And this is with specific reference to the non-steroidal anti-inflammatory drugs, which inhibits the peripheral COX. Now, its main action is antipyretic and analgesic. It does not have any anti-inflammatory action, which is actually a drawback of paracetamol. What are the doses? It is safe to give a dose of 12 to 15 mg per kg every 6 hours, up to 3 grams a day. And the daily dose should not exceed 4 grams, and a single dose should not exceed 1 gram. Normally, we give 650 mg paracetamol, but now paracetamol sustained release tablet of 1 gram is also available, of which 300 is released immediately and 700 is released over the course of the day. You can also give paracetamol as an infusion, 1 gram every 6 hours. So these are the various routes you can give. It can even be given rectally. Very safe for pediatric use, up to 15 mg per kg every 6 hours. And toxicity occurs in doses of only more than 90 mg per kg per day. Now, numbers needed to treat. NNT. NNT is it's a number of patients who receive a drug for one to have 50% relief of pain over the next 6 hours compared to a control. So this is used to gauge the efficacy of an analgesic. Now, in case of paracetamol, the NNT is 5. The lower the NNT, the more efficacious is the analgesic. So paracetamol has not a highly efficacious drug, but it is moderately efficacious. What are the advantages of paracetamol? It has a very good safety profile. Undesirable effects are less. It has no effect on the gastric mucosa, less chances of peptic ulcers and acidity problems, no adverse renal effects, no effects on platelet function. That means platelet aggregation is not hampered. It can be tolerated to patients who are allergic and who have hypersensitivity, especially to ecosprin, aspirin. And it does not affect the plasma uric acid levels. But there are certain drawbacks of paracetamol. That is, it has to be given every 6 hours. It has no anti-inflammatory action, and it has a potential for hepatotoxicity in high doses of more than 4 grams a day when there is impaired liver function and alcohol consumption, excessive alcohol consumption, or if the body weight is less than 50, then you have to restrict the total dose to 2 grams. It is safe in liver disease in doses up to 2 to 3 grams per day. Now, like I said, it has a very good safety profile. It has also got an opioid sparing effect. If you add it with an opioid, you can actually bring down the dose of opioids that you're given. And it is usually added to every step of the ladder. It can be combined with NSAIDs, with tramadol, or even with opioids. Now we come to non-steroidal anti-inflammatory drugs. These are drugs that act on the peripheral cyclooxygenase system. Now, this peripheral is a very important enzyme in the arachidonic acid cascade, which produces the tissue and the inflammatory prostaglandins. Now, prostaglandins are very important intermediaries of pain, and they cause what is called peripheral sensitization. In my next slide, I will tell you a little more of that in detail. Now, whenever there's tissue damage, you know there's a lot of release of the tissue byproducts and inflammatory mediators. So they form what is called a sensitizing soup. And this sensitizing soup, when it bathes the nociceptor, it increases the excitability and irritability of the nociceptor. And this leads to amplification of pain signal. This is what is peripheral sensitization. So it is diagrammatically represented here, in which you see the tissue injury. You have the release of all these mediators, and then you have the nociceptor. Okay, this is a nociceptor, and this is a peripheral neuron, that is the first order neuron. And all these drugs are acting at this level. The anti-inflammatory drugs, NSAIDs, are acting at this level by preventing peripheral sensitization. Okay, that is where it is at. Now, like I said, you have a tissue injury, the release of all these phospholipids, they're converted to arachidonic acid, which is converted to prostaglandins because of the cyclooxygenase enzyme, which is COX-2. This is released only when there is an inflammation. Okay, and this produces all the inflammatory signs of inflammation, pain and swelling and redness and all that signs of inflammation. But there is another COX, which is actually a housekeeping enzyme. So cyclooxygenase exists in two forms, COX-1 and COX-2. COX-2 is released when there is an injury or inflammation. COX-1 is normally present, and it is a housekeeping enzyme It actually mediates the physiological responses in our body, like protecting the stomach, the kidney, and facilitates platelet aggregation, etc. And I said COX-2 occurs only when there is inflammation. So it's induced only when there is an inflammation. So the NSAIDs are of two types. The non-selective NSAIDs are those which interferes both with COX-1 and COX-2. It inhibits both. Whereas selective COX-2 are inhibiting only the COX-2 inhibitor, COX-2 enzyme, and it is not affecting the COX-1. That means it is allowing the normal body functions to be maintained. The housekeeping functions are being maintained. So even if you want to classify NSAIDs, non-selective NSAIDs, you have the salicylates, which is aspirin. Then you have ibuprofen, naproxen, ketoprofen. Then you have the diclofenac. Now, diclofenac can also be a selective COX-2 inhibitor also. Then you have piroxicam, ketorolac, indomethacin. So these are all the non-selective COX inhibitors. Now, I said because of the inhibition of COX-1, it produces the side effects like GI side effects, bleeding, hypersensitivity reactions like angioedema and bronchospasm, and also adverse renal effects. But by inhibiting the COX-2 enzyme, it is producing the anti-inflammatory effect, and it exerts beneficial effect. That is anti-inflammatory, analgesic, and antipyretic. So non-selective NSAIDs is a double-edged sword with both adverse effects because of COX-2 inhibition, because of COX-1 inhibition, and beneficial effects because of COX-2 inhibition. Now, some of these drugs are ibuprofen. Its NNT is 2. That means for every 2 patients, 1 will get relief. It's very good analgesic, very efficacious. Similarly, naproxen, its NNT is 2.7. This also can be given orally or by suppository. Now, what are the side effects because of the COX-1 inhibition? I've already told about it: renal, gastrointestinal, and hypersensitivity reactions. Now we talk about selective COX-2 inhibitors. So they are only inhibiting the COX-2 enzyme, and COX-1 enzyme is preserved. So the examples are etoricoxib or Nucoxia in a dose of 60, 90, or 120 mg once a day only. Celecoxib, 100 or 200 mg twice daily. And like I said, diclofenac can be actually classed as a COX-2 inhibitor. Its NNT is also very good. Its NNT is 2. Okay. NSAIDs can also be given topically. It produces a good analgesic effect with less risk of systemic absorption and toxicity. And we have a variety of gels and creams containing ibuprofen, diclofenac, piroxicam, ketoprofen, etc. But the question is, are selective COX-2 inhibitors safe as compared to non-selective inhibitors, COX inhibitors? Where the GIT is concerned, it has definitely got an advantage. It is safe. But where the renal damage is concerned, it is comparable with non-selective NSAIDs. But the flip side is that it has a prothrombotic effect. That is, the selective COX-2 inhibitors can be prothrombotic, and there is a likelihood of causing myocardial infarction and stroke. In fact, COX-2 inhibitor rofecoxib was taken off the US market in 2004 because of these adverse effects that were reported. So in such patients who have a sort of high risk for atherosclerosis and high risk of thrombotic events, then the drug of choice would be ibuprofen and naproxen. So the risk factors that you need to keep in mind when you're giving NSAIDs is, for GI, you have to be very careful when we give it in patients with upper GI symptoms or bleeding. For renal, you have to be very careful that you hydrate the patients well, otherwise they can land up with renal dysfunction. And also you have to give it when the creatinine clearance is low. You have to be very cautious and avoid it also. But when there are risk factors for stroke and MI, like patients with advanced age, diabetes, hypertension, hyperlipidemia, smoking, and history of TI or stroke, then you should avoid COX-2 drugs. Now coming to the step 2 drug of the analgesic ladder, They are controlled drugs. They are not controlled drugs. That means unlike morphine, it is not controlled. That means you can procure it more easily without too much of in a controlled drug, it comes under the NDPS Act. So this doesn't come under that. So they are called weak opioids. And they are given for pain of moderate intensity, which is not controlled with step 1. And some of the example that I will be talking about will be only tramadol and tapentadol, because that is what is available with us now. But tramadol is a centrally acting synthetic weak opioid. It has two methods of action. One is it is a weak opioid agonist. So because it's a weak opioid, it has got less tendency for respiratory depression and addiction potential. But it also acts on the descending inhibitory pathway of pain, and it blocks the presynaptic reuptake of serotonin and norepinephrine. So it has got two ways of action. And so because of the second effect, that is the inhibitory pathways are being, descending pathways are it activates the inhibitory pathway. Because of that, it can be used for neuropathic pain as well. Okay. And normally we use a combination of tramadol and paracetamol, widely used as a step 2 drug. Now tramadol, it's got a high oral bioavailability. Its plasma half-life is 6 hours. Its oral dose is very potent. It's 1/10 as potent as morphine. That means if you're giving 100 mg, it is for 40 mg morphine is equivalent to 400 mg of tramadol. So the dose is 50 to 100 mg every 4 to 6 hours, and you can go up to 400 mg. Nowadays, sustained release formulations, twice daily dosing is also available. It has got some side effects like nausea, vomiting, dry mouth, constipation, dizziness, sedation. And there could be a risk of seizures when the total dose exceeds 400, when it is given along with drugs that lower the seizure threshold, like tricyclic antidepressants and SSRIs. Excuse me. And also, whether you give it rapidly intravenous. So normally you give it as a slow IV injection. Now, tapentadol is the other weak opioid, which is a more recent drug, and it is very structurally related to tramadol. Its method of action is also similar to tramadol, like I mentioned earlier. But the side effect profile is slightly better. The dose is also comparable to tramadol. So when you look at analgesic combinations, we should never use two drugs of the same category. For example, you don't use two strong opioids. We don't combine fentanyl with morphine, okay, or methadone with morphine. But the drug combinations, or similarly, you don't combine a COX-1 and a COX-2 inhibitor. But the drug combinations that are favorable are when you want to give paracetamol or NSAIDs with morphine, or paracetamol with NSAIDs, or paracetamol with tramadol. So those are the favorable combinations. Now let's come to neuropathic pain. Now, cancer pain is multifaceted. Okay, it is not just because of tissue injury or nociceptive. It could be, there could be bowel obstruction pain or spasmodic pain. There could be bone pain. 40% of cancer patients have neuropathic pain. There could be other symptoms, and there could be even muscle spasm. And that is where the role of adjuvant drugs come into the picture. So adjuvant drugs have analgesic properties, but the primary indication is not for pain. For example, an anticonvulsant. It is used to treat seizures, but it has got effect on neuropathic pain. So the primary indication could be for seizures, but it has got analgesic properties. So they're also called co-analgesics because they are co-administered with drugs of the WHO. So these are the classification of some of these adjuvant drugs. You have multi-purpose drugs like antidepressants, corticosteroids, alpha-2 agonists. You have drugs for neuropathic pain. You have drugs for bone pain. You have drugs for bowel obstruction, and you have drugs for musculoskeletal. So these can be combined with your step 1, step 2, and step 3 analgesic drugs, depending on what the patient has. Now, Just a little bit on recapitulating what is nociceptive and neuropathic pain. Nociceptive pain is because of tissue injury and it occurs at the periphery where the nociceptor is there. Anything beyond this in the peripheral nerve or in the dorsal horn or in the spinal cord or in the brain comes under the category of neuropathic pain. So, according to the definition, it is neuropathic pain is caused by a disease or lesion in the peripheral or central nervous system. Sometimes the pain can be a combination of nociceptive and neuropathic. Why does it occur? It occurs because of direct invasion or compression of the nerve, or it could be because of the treatment of cancer, like chemotherapy can cause damage to the peripheral nerves, causing chemotherapy-induced peripheral neuropathy, or it could be radiation-induced. It could be due to surgical excision of the tumor when there's injury to a nerve. But sometimes this pain can persist even months and years after the cancer is cured. Even in cancer survivors, you can still have neuropathic pain, okay, because of the damage to the nerve that has occurred, which has not come back to normal. So anticonvulsants. So this is one of the first line treatment for neuropathic pain. And why is it used for neuropathic pain is because both epilepsy and pain have a common underlying pathophysiology. In both, there is neuronal hyperexcitability, and these drugs can dampen the neuronal excitability. And these are the commonly used anticonvulsants in pain. So how does it act? These gabapentinoids bind to the voltage-gated calcium channels and prevent the influx of calcium into the presynaptic neuron, because of which there is less release of the neurotransmitter, which are the excitatory neurotransmitters like glutamate, aspartate, etc. And because there is less release of this postsynaptic, this is synapse, okay? The postsynaptic membrane is less activated because there is less release of these neurotransmitters. It also can act on the sodium channels, and it can also enhance the GABA-mediated synaptic inhibition. So these are the other methods by which these gabapentinoids act. So the advantages, very good for neuropathic pain, tolerated well, less chance of drug-drug interaction, and does not induce hepatic enzyme. But the side effects are, it can cause somnolence, dizziness, weight gain, ataxia, fatigue, etc. So these are the drugs that are commonly used anticonvulsants. We have gabapentin, which is less expensive, and pregabalin, which is more expensive. So you can use either of them, except that with pregabalin, you can titrate it faster as compared to gabapentin. Now, these anticonvulsants are now also available for topical use, or rather, like gabapentin is now available as topical creams. So if the patient is having a localized area of neuropathic pain, you can also apply that. The other topical drug for neuropathic pain is capsaicin 8%. It is a pungent component of our chili pepper, but it is not freely available in India. Now, the other drug that is a first-line treatment for neuropathic pain is the antidepressants. Now, its onset of action takes up to 1 week, and the analgesic effect is not dependent on the antidepressant effect, because the antidepressant effect takes longer to happen. So analgesic effect can occur earlier and at much lower doses as compared to the antidepressant. And it is very useful in cancer patients because these patients invariably have depression, anxiety, insomnia. So when you give this for neuropathic pain, it is also treating these other symptoms also. How does it act? Again, it acts by preventing the reuptake of norepinephrine and serotonin at the dorsal spinal cord synapses. And also it activates the descending inhibitory pathway of pain. So these are the antidepressants in clinical use. We have the tricyclic antidepressants, which are amitriptyline, nortriptyline, desipramine, imipramine. Then the selective serotonin reuptake inhibitor, or SSRI. They are escitalopram, citalopram, paroxetine, fluoxetine, sertraline. Then you have the SNRI, or the serotonin norepinephrine receptor inhibitor. The drugs that are commonly used are duloxetine and venlafaxine. Besides this, recently more drugs have been added, antidepressants, like mirtazapine. This is also now being used for treatment of depression and pain. And you have atypical antipsychotics like quetiapine, risperidone, or olanzapine. These also can be used for treatment of depression along with the pain. So the commonly used drugs, however, are the tricyclic antidepressants, the SNRI, and the SSRI. If you look at the analgesic efficacy, the TCA would be more efficacious than SNRI, which is more than SSRI. But if you look at the side effect, the TCA will have more side effect as compared to the SNRI and the SSRI. So let's look at the side effects of the tricyclic antidepressants. Where the central nervous system is concerned, they can complain of somnolence, drowsiness, mental clouding, and even suicidal tendency. But because of its antimuscarinic or the anticholinergic effect, you can have dry mouth, acute angle glaucoma, blurred vision, tachycardia, urinary retention, constipation, and orthostatic hypotension. So the contraindications accordingly, avoid it in patients with severe cardiac conduction defects, arrhythmias, etc. Avoid it in patients with prostatic hypertrophy, and avoid it in patients with glaucoma, particularly narrow angle glaucoma. Where the SNRI is concerned, again, the side effects, somnolence, dizziness, constipation, anorexia, hyperhidrosis, impaired sexual function, and suicidal risk. And that is more with SSRI as compared to SNRI. So the contraindications are, you should avoid venlafaxine, particularly when there's hepatic and renal deficiency and when the BPs are high. And duloxetine can be avoided when there is a hepatic insufficiency. The doses of these anticonvulsant drugs, always we start at low doses, like amitriptyline started at 10 mg. And then you can go up after 5 days, you can slowly step it up. Duloxetine also 30 mg we start with, and venlafaxine 37.5 mg. Anticonvulsants, again, we start with a dose of 100 mg at night, and then we step it up. Similarly, pregabalin, we start at 75 mg. And please remember, all dosage adjustments should be done for the medically ill and patients with renal dysfunction and with other comorbidities. Now, this was a study on the role of duloxetine in patients with chemotherapy-induced peripheral neuropathy, published in 2013, and in which these patients received duloxetine as initial treatment from weeks 1 to 5. They had larger decrease in pain as compared to placebo-treated patients. So the latest guidelines, 2020 guidelines, do suggest duloxetine for the initial treatment of painful CIPN for 5 weeks. What are the other drugs used in neuropathic pain? Ketamine. Ketamine can be used because it is an NMDA receptor blocker and which is at the dorsal horn of the spinal cord. It can also be, NMDA receptors can also be present in the thalamus. So these NMDA antagonists are used when neuropathic pain are unresponsive to the antidepressants and the anticonvulsants. Ketamine, this is the example of an NMDA antagonist, but the side effects are dysphoria, hallucinations, nausea, vomiting, and you can prevent it by giving drugs like haloperidol and benzodiazepine. It can be given in a variety of routes: IV, IM, SC, oral, sublingual, intranasal, rectally, topically, intraarticular, epidural, and even intrathecal. Its IM bioavailability is very high, 90% at 5 minutes. Oral is lesser at 20%. Now, ketamine is normally an anesthetic drug, but in sub-anesthetic doses, it is very effective for treating neuropathic pain. So oral ketamine, you give in a dose of 10 to 25 mg, and subcutaneous or IV ketamine, you can go up to 50 to 100 mg per day, maximum 200 mg. And sometimes for treatment of intractable pain, we use what is called a burst ketamine infusion. I discuss this when we are discussing difficult pain. Local anesthetics can also be used to treat neuropathic pain. It is reserved for the crescendo neuropathic pain, which is intractable to treat. It can be given as a local IV local anesthetic infusion. You use Xylocard because that doesn't have the preservative in it. Okay, and you give a 5 mg per kg dose added to 500 ml of normal saline, and you give it over 1 hour with cardiac monitoring. So this has to be done under daycare procedure with cardiac monitoring. Topical lidocaine patches are also available. 5% patches are now available. You can apply up to 3 patches. But just remember, apply it for 12 hours and remove for the next 12 hours so that local anesthetic toxicity does not occur. I've got another 5 minutes, I think. So if you look at the first line drugs for neuropathic pain, they include amitriptyline, pregabalin, gabapentin, duloxetine, lidocaine patch. Second line are opioids and tramadol. And third line are baclofen, mexiletine, capsaicin patch, and ketamine. A capsaicin patch I mentioned, 8% patch can be applied. 1 to 4 patches in the painful area for 30 to 60 minutes and can be applied every 3 months. So coming to the corticosteroids, they are a multi-purpose drug, so it can be used to treat a variety of neuropathic pains, like I mentioned over here. Okay. Now, out of all the steroids, dexamethasone is a one that has got a very strong anti-inflammatory action. It's 50 times more potent anti-inflammatory than hydrocortisone. And so the duration of action also, just see, it is 36 to 56 hours. So it can be given just as a once a day dose. So like I said, it has a very potent anti-inflammatory action with less mineralocorticoid effects. So less chances of sodium and water retention. But because it can cause insomnia, it's given in the morning. But it has been found that steroids provide short-term relief of pain, and it is beneficial for those patients with less life expectancy. And these are the doses for metastasis: 4 to 8 mg up to 16 mg. For malignant bowel obstruction, 6 to 16 mg at 24 hours infusion. It can also be given as an appetite stimulant in cancer. Now, GABA receptor agonists, there are two types of GABA receptor agonists. One is benzodiazepine, which acts on GABA A, and baclofen, which acts on GABA B. The only benzodiazepine that is effective for neuropathic pain is clonazepam, which is given in a dose of 0.5 mg per oral. It can also be used for terminal sedation. Now, baclofen is the GABA B agonist, and it can be given whenever there is associated spasticity, neuropathic pain, hiccup, musculoskeletal spasms, etc. Bone pain. Metastatic bone disease can cause what is called skeletal-related events, and out of which bone pain is very, very important. It can be very agonizing and affects the quality of life. The various drugs that are given for bone pain include corticosteroids and NSAIDs, calcitonin, but recent reviews show there's no significant improvement in quality of life. But the important ones that we use are the bisphosphonates and denosumab and palliative radiation. Now, bisphosphonates acts by blocking the osteoclastic activity and bone resorption. Zoledronic acid is the one commonly used. You give in a dose of 4 mg IV every over 15 minutes and every 4 weeks for 1 year. But it has got side effects like pyrexia, renal dysfunction, hypocalcemia, and sometimes even osteonecrosis of the jaw. When you want to compare two of these drugs, denosumab and zoledronic acid, although the zoledronic acid is more cost effective, but the advantage of denosumab is that it can be given subcutaneous, less risk of renal toxicity. And it is superior in preventing and delaying the skeletal-related events with a better median survival rate. But the main drawback is it's very expensive. So if you look at the cost of the drugs, denosumab for a monthly cost is 32,000, whereas zoledronic is just around 900 rupees. And palliative radiation can also be given, and it can treat bone pain, but the drawback is it takes several weeks for pain relief. And the agents used are strontium and samarium. For malignant bowel obstruction, you can use steroids, you can use octreotide, which is a somatostatin synthetic analog, or you can use anticholinergic drugs like hyoscine and glycopyrrolate. The other adjuvant drugs are muscle relaxants like thiocolchidoside, tizanidine, neurolepts like olanzapine, and so many other adjuvant drugs that can be used. So if you look at this diagram of the pain pathway, you can see how these drugs are acting at different steps of the pathway. The muscle relaxant is acting at the muscle level. Okay. At the nociceptor level, you have the non-steroidal anti-inflammatory drugs and the local anesthetics. And the drugs that prevent peripheral sensitization are local anesthetics, topical analgesics, antidepressants, anticonvulsants, and opioids. The drugs that act at the dorsal horn, that is here, are the anticonvulsants, antidepressants, opioids, and NMDA antagonists. And the drugs that act on descending modulation are the opioids, the alpha-2 agonists, the tricyclic antidepressants, and the SNRI. So coming back to a scenario, we said this patient had pain, and it was mainly a gnawing pain in the shoulder with tingling in the arm, which was more at night, right? And he was unable to sleep. So if you look at the intensity of pain, you can classify it as mild to moderate. The type of pain, it was nociceptive in the shoulder and neuropathic in the arm. So it was a mixed type of pain. And it had a temporal nature. It was worse at night. And he had a lot of functional, emotional, social, and financial issues. And as a result of which he was unable to sleep. So how do we address this patient? So we can start with step 1 drugs. You can give a combination of paracetamol with NSAIDs. But because he has more pain at night, maybe we can give him a long-acting drug at night, like paracetamol 1000 mg. I mentioned about the sustained release tablet, and also the sustained release diclofenac, so that the whole night is tided over. You can add an anticonvulsant antidepressant for the neuropathic pain. You may have to give an adjuvant drug for better sleep. And also important is to address the psychosocial concerns. To summarize, the WHO analgesic ladder is a sheet anchor for cancer pain management. It can also be used for non-cancer pain. It's very simple, easy to implement. It can be used worldwide, and it has legitimized the use of opioids in cancer pain.
Thank you so much, ma'am. We'll wait for some time if there are any questions based on today's session. Participants can either unmute or type it in the chat. Yes, Dr. Sarah.
Hello. First of all, hi ma'am. It was a very informative and very good presentation. I'd like to ask that you said something about PRN and around the clock, by the clock we have to give the drugs. But what if the pain starts before the T half? Like suppose T half of morphine is 4 hours. What if like the person starts complaining of pain at 2 hours? So can we like add more drug?
See, this is what will be discussed very much in detail when we are talking about the step 3 drugs. But if the pain occurs after 1 hour of the drug, that means it is occurring at the 2nd hour or the 3rd hour, that is called a breakthrough pain. Okay. So at that stage, you can repeat the dose of the morphine or whatever drug you're giving. Like if it's morphine, if it's after 1 hour, you can repeat that same dose. If the patient was taking 5 mg Q4H, then at 2 hours, if he has pain, please repeat that 5 mg. No problem. It's the only thing you have to wait for 1 hour after the drug to give the second dose. And then you have to calculate in a day how many extra doses he has taken. And at the end of it, you recalculate the total requirement based on these extra doses have to be also factored in. So this is called breakthrough pain, and this has to be treated. You should not allow it to persist.
So the next dose or the next day will decide upon, like it will be an individual.
You wait for 3 to 5 days, keep giving it like that. The actual escalation should be done after the stabilization. So it waits for 3 to 5 days. Then you calculate how much he has required in a day. And if according to that, then you have to recalculate for every 4 hours. With the same instruction. Now he's on 10 mg every Q4H. But you have to tell him that for breakthrough pain, you have to repeat an SOS dose of 10 mg after 1 hour, if the breakthrough pain occurs.
Thank you so much. Thank you.
Thank you. And adding on to that, as Madam mentioned, next session on opioids, we'll be having a lot of case scenarios discussion based on these kind of calculations. Yes, Dr. Sharon.
Unmute yourself.
Yes, ma'am, and thanks for very informative guidance. And I want to ask is for patients who has at risk of seizures, like brain tumors, like primary or secondary brain tumors, should we need to avoid tramadol for pain relief?
Yeah, this is a similar question I get asked every time. Okay,
Yes.
a very important drug in our management. And in
Yeah.
patients with brain tumors, can you give tramadol or not? It's a very intelligent question also, but you can safely give tramadol. Okay, but avoid giving a fast IV bolus and avoid, I mean, you have to make sure, I mean, they may be on antidepressants. You have to be just careful about it, but we can give tramadol even in patients with brain tumors. Okay, no problem. Because I'm a neuroanesthetist, no, so I've used tramadol widely in my practice. There's no problem. It doesn't increase the ICT, and if you give it carefully, then it will not cause any seizures. But you have to be careful when you're giving it with SSRI and antidepressants that can lower the seizure threshold. You have to be a little careful by giving. But there's no contraindication.
Thank you, ma'am.
Dr. Sharon?
Yes, ma'am, thank you for your talk. I just have actually a couple of questions and a comment. The first question is, can we combine two types of adjuvant analgesics, especially like tricyclics with, let's say, gabapentin or pregabalin or mirtazapine, if we've reached the maximum dose of, let's say we started with amitriptyline, we've reached the maximum dose, neuropathic pain still persists, and there is no facility for doing interventions like nerve blocks. So is there a rationale of combining, of then starting a second type, different category of adjuvant for neuropathic pain?
I'll answer this question first. See, the original neuropathic pain ladder was at step 1, you give either an antidepressant or an anticonvulsant, either. Responding, then you have to combine the two. So it can be safely combined. Gabapentin is very often given with an antidepressant, or pregabalin can be given with an antidepressant, no problem. It is the combined effect. Very commonly, we are giving a drug like gabapentin with nortriptyline combination. It's a combination, tablets are available. So it is, if it is not responding to single line, either anticonvulsant or antidepressant, you can combine the two, no problem.
Right. My second question is, let's say I have a patient, who has, let's say, a pancreatic tumor. Pain is controlled with step 3, like morphine, high dose morphine. But even though the pain is controlled, in view of non-availability of morphine or anticipated non-availability of morphine, can we go on to step 4, even if pain is controlled on step 3, to anticipate or to reduce the opioid requirement in a setting of questionable morphine availability? Like, can I send that patient for celiac plexus block, even though, right, let's say he's taking 20 mg morphine every 4 hours and pain is controlled, but I don't know what my availability of morphine will be like after a month. So is there an allowance for going straight to step 4?
See, step 4 are interventional procedures.
Right.
Okay,
yeah.
It has its beneficial effects and its side drawbacks. So it is, you have to calculate the risk benefit ratio always. Okay, so when the pain is controlled, why go in for an intervention? Because it's not that it is a totally innocuous procedure, and it is not that it will produce 100% pain relief. Okay, nobody will say that. I've seen patients even after neurolytic block still having pain. And there are also the dangers of the intervention itself can be there. So I think if the patient is well controlled on a non-invasive thing, I think only if it's intractable pain, then I feel that.
Right, ma'am. Yeah. And a third is just a comment regarding palliative radiation. I think it's just my suggestion that actually external beam radiation is the one that is more commonly used to palliate bone pain because simply because the radioactive isotopes, the bone loving radioisotopes are not very easily available. It's only in this a handful of centers. So I think palliative external beam radiation is still the mainstay of palliative radiation for painful bone meds. Thank
What
you.
is used for external radiation, external beam radiation?
A cobalt unit, a cobalt machine is enough to treat for palliation of bone meds.
Very specific also, is it?
Uh,
Focus.
It wouldn't be as focused as your as let's say the conformal techniques like 3D CRT IMRT, but in view of just the aim being palliation and keeping in mind resources and cost, that is what is used. It's not as focused, but it's given just with a few centimeters of margins on either side of the area of bone pain.
Okay, thank you for that information.
Thanks, ma'am.
Thank you, Sharon, for that information. There is a chart by Dr. Dhanwandi. Can tramadol, does it have an addictive potential? And the same, another question on tramadol, is it necessary to give MSIT with tramadol? So there are two questions on tramadol.
See, where the addiction potential, it's a weak opioid. And weak opioid, so there's very less risk of addiction potential. That is the advantage over the other drugs. So I think the risk is very little for addiction potential. It can be combined with MSET because quite often you can, like at least in the operating room when we used to give tramadol, we used to always give MSET. But when you're giving it on a routine basis for tablets, I think only if they have symptoms then you have to give MSET. I don't think it has to be given. Sri Devi, what is your take on this? I don't think routinely we prescribe MSET along with tramadol. But
we do give antiemetic, but we do give metoclopramide for every time we prescribe tramadol, every single time for the initial few days, because we do get a lot of nausea and vomiting and then people stop taking tramadol. So it's a mandate that you have to prescribe metoclopramide along with tramadol.
And metoclopramide has its own beneficial effects in these cancer patients.
Yes.
So it can take care of both that also, that
yes.
motility and everything is improved and everything.
Dr. Vandana?
Yes, ma'am. Thank you, ma'am, for the opportunity. Thank you, ma'am. Ma'am, I have two questions. One is, when we know the adverse effects of the drugs that we are using, for example, as already for tramadol, we know that the patient is going to have MSS. So, madam has clarified that generally we prescribe metoclopramide every time we are prescribing tramadol. So, is that the same case for other drugs? For example, like, do we give antacids when we are prescribing every single time? Should you give an antacid when you are prescribing NSAID? Do you give benzodiazepines when we are prescribing ketamine? Do we always start along with the treating the adverse effect, or we wait for the patient to come back and then give this? That is one question I want to ask.
Okay, I'll just answer that one and then we'll move on. See, the thing is, like, certain drugs have got a high propensity for a particular side effect. For example, when you're giving steroid, it is absolutely imperative to give a proton pump inhibitor. Okay, so you have to give a drug like to reduce the acidity. That is very, very necessary. If you write steroid, you have to write an antacid also. Okay, one of the proton pump inhibitors. But things like which have got a high tendency to cause a side effect, it is better to give the that particular antidote also along with the drug. For example, NSAIDs, when you're giving, it is either you have to tell them to take it after a meal, or you have to say that if they have a tendency for acid peptic disease, then we have to treat it also along. That is one question.
Okay. Yes, ma'am. Yes, ma'am. And another question, thank you, ma'am, for that clarification. And another question is regarding the steroids, ma'am. what is the, how do we start the steroids? Because we know that it is going to suppress the adrenal glands over a period of time. So how exactly should we practice it? We start with low dose, alternate it, or taper it. How do we exactly do it when we are adding it on?
Yeah. See, for example, if a patient has got, say, brain metastasis, okay, then, and if the patient has got headache, that is because of the edema, which is causing a rise in ICP. So we give dexamethasone. Normally, we give it in a dose of 8 milligram per kg, depending upon the severity of the, how bad the metastasis is. So 8 mg, single dose over 7 days or 5 to 7 days and stop.
Oh,
Okay, even for any symptom which requires steroid, if you're giving a short course like that, you don't have to
Yeah.
taper it off
Yeah.
also, you
yeah,
know.
yes, ma'am. So 1 week is the time that we generally try to
7
limit
days,
it
yeah,
to 1 week,
yeah,
and then
yeah.
after that, we.
But beyond that, it will cause more side effects and less benefit.
Ma'am, we lost your voice now suddenly. No, we can't hear you. It was audible. Suddenly, just some disc. Yeah, now you're audible.
So like I said, if you're giving a short-term course, like 5 to 7 days, you don't have to taper it off. And it can, like in particularly patients with advanced terminal cancer, it can cause a lot
Yes,
of relief,
yes,
you know,
ma'am. Yes.
lot of relief, but the relief again is not prolonged for too long, but it will, at least it will buy time for you.
Okay. So we try to limit it for around a week, and then we give it a gap. And if required, if there are signs of inflammation, and again, if it is required, we restart it in the same pattern. That is what we try to do, right?
Maybe, but at least you don't give it for more than a week, because if you
Week.
go beyond that only, then
Yes,
adrenal
ma'am.
suppression.
Then, yes, ma'am. Yes. Okay. Okay. Thank you.
Thank you, Dr. Vandana. So, just to add on to the first question, there are a lot of studies showing the strong association between NSAIDs and the potential gastric erosion. So, they say it may not be symptomatic in the beginning, but you end up with having erosions and it will be very late presentation. So, they strongly recommend the guidelines, all the guidelines strongly recommend to give PPIs whenever you start with an NSAID, even if the patients are symptom free. So, that's just one thing I would want to add. Dr. Dhanvanti, was there any question? I saw your hand raised some time back.
Hi, yes, actually, I wanted to ask about a patient who is a known case of Parkinson's disease. She's on an anticonvulsant, she's on several antipsychotic drugs like amitriptyline, as well as she's taking gabapentin up to a dose of 1200 milligrams a day. She has tried and exhausted her options of crocin and diclofenac she's taken on and off. She's reluctant for an opioid, but my biggest concern is, will an opioid help the type of pain like that is in present in Parkinson's disease?
See, for non-cancer patients, we have to use severe, strong opioids with caution. And also we need to know what kind of pain this patient has. The pain I told you can be nociceptive, neuropathic, it can be mixed. It is very important to assess the kind of pain that she has. Is it a nociceptive pain? Is it a neuropathic pain? Then accordingly treat it. Okay. So see, in Parkinson's, if there is a lot of muscle spasm, the pain could be because of spasticity also. Okay. So then you have to think of adding an adjuvant drug. So you need to dissect it out, you know, dissect it out. What is the pain? Why is it happening? Where is the pain? We can't generalize it that patient has pain, and you know, you have to see what kind of pain it is. And that happens, proper history, examination, is there rigidity, everything you have to see, and then you have to take a call whether the patient needs and is it a neuropathic pain or is it because of the muscle spasm and rigidity? The pain is happening, in which case you may have to add a muscle relaxant, you know, so that is very important. So it's, but otherwise for non-cancer pain, I would advise a lot of caution when you're starting a strong opioid. because the thing is then it will be going on indefinitely, and there could be a problem regarding addiction in these. So you have to use strong opioids with a lot of caution when you're using it for non-cancer patients.
Thank you, ma'am. Maybe one last question before the case presentation. Which analgesic is safe in asthmatic patients?
Okay, in asthmatic patients, I would prefer to avoid NSAIDs because it can cause hypersensitivity. So in such cases, I think either paracetamol or tramadol is quite good.
Thank you. So we'll move on to the case presentation and then we'll take a few questions after the presentation. Dr. Sharon?
Yes. Shall I start?
Yes, please.
Okay. So today's case presentation, the patient is a 58-year-old female with the diagnosis of the first metastatic squamous cell carcinoma of the right pelvic bone. The second is squamous cell carcinoma cervix stage 2B in 2005 treated, that is post-radical chemoirradiation, post-brachytherapy and hysterectomy, and currently in remission. The presenting complaints, the patient presented in May 2021 with complaints of moderate pain over her right hip and tingling and burning sensation over the right lower limb for 1 month. There was no history of weakness or decreased sensation over the lower limbs. She had normal bowel and bladder habits. The history of the presenting illness, the patient was well till about a month back when she complained of pain over her right hip, accompanied by burning and tingling sensation of her right lower limb. The pain over her right hip was gradual in onset, slowly progressive, continuous and dull aching in nature. It was aggravated by movement and relieved, partially relieved at rest. Her pain score at that time, numerical pain score was 8/10. She also complained of a continuous tingling and burning sensation over her entire right lower limb with no particular aggravating or relieving factors. Now, the pain was initially mild and gradually progressed to moderate in intensity. Her sleep was disturbed due to the pain, and she also complained of difficulty in walking due to the pain. Coming to the significant past history, the patient was diagnosed to have squamous cell carcinoma cervix stage 2B in 2005, and she was treated with radical chemoradiation followed by intracavitary brachytherapy and then hysterectomy. And subsequent regular follow-up visits showed no evidence of malignancy. The patient had no other medical comorbidities. On examination, her general examination showed a pulse rate of 98 per minute, BP of 110/70 millimeters of mercury. She was afebrile. There was no pallor, icterus, clubbing cyanosis, edema, or lymphadenopathy. She had an antalgic gait and used a walking stick. Her performance status was otherwise good. Coming to a systemic examination. The examination of the CVS, respiratory system, and abdomen was normal. Examination of the CNS showed no focal neurological deficits. There was no skeletal or vertebral tenderness. And a pelvic examination showed a smooth vaginal vault and parametria, and rectal mucosa and lumen were normal. So the investigations that were advised were a complete blood count, a kidney function test, a liver function test, and random blood sugar as part of our evaluation, as well as prior to starting any medications. Imaging investigations that were advised to evaluate the pain were X-ray pelvis and lumbosacral spine. a contrast MRI of the abdomen and pelvis, and a chest X-ray to rule out metastasis. So coming to the treatment, the first part of the treatment was the pain management. So she was started on WHO step 2 analgesics. She was started on TAP tramadol 50 mg thrice daily, as well as whenever required. For the neuropathic component, she was started on TAP pregabalin 75 mg HSOD. After a normal kidney function test report, TAP aceclofenac 100 mg twice daily after food was added, with TAP ranitidine twice daily. And preemptively, she was advised TAP bisacodyl 5 mg if she developed constipation, and TAP domperidone 10 mg if required for nausea. Coming to the disease-specific management, on evaluation, the patient was found to have a large infiltrative lesion involving the ileum of the right pelvic bone. There was no obvious primary malignancy and no other distant metastasis identified after further evaluation. So only the iliac of the pelvic bone was involved. A CT-guided biopsy of the right pelvic bone lesion was done, which showed metastatic squamous cell carcinoma. So she was treated with palliative radiation to the right pelvic bone, 30 gray in 10 fractions. Subsequently, she also received palliative systemic chemotherapy. And at the end of radiation, her pain had reduced significantly. The pain score was about 3. She was able to walk comfortably on level ground and with mild difficulty while climbing stairs. Coming to the psychosocial aspects of this patient's condition, the pain restricted the patient's mobility and ambulation, and hence she was not able to perform her activities of daily living, such as bathing, housework, cleaning the house. And it also made it difficult for her to squat and to use the Indian type of toilet in her home. So she had to purchase a portable toilet seat, and she found this awkward and embarrassing to use. Her social and religious life was also affected, as she was unable to visit her relatives' houses. Neither was she able to attend church services. She was unable to perform housework or go to the market. So she felt useless. She felt a burden on her children. Her children had to take leave from their respective workplaces to care for her. And she was also fearful that this pain was a sign of advanced and incurable cancer. So the medications, as stated earlier, TAP tramadol, after radiation therapy, when the pain reduced, it was changed to TAP Calpol-T or Ultracet. And TAP pregabalin was continued, aceclofenac, bisacodyl, and domperidone. So the main concerns for this patient were pain, and then second, restricted mobility and difficulty in performing activities of daily living. Third was the disturbed sleep at night. Then fourth was her anxiety about cancer being the cause of pain, as well as incurability of the cancer. And the last was anxiety about being dependent on her family members for her activities of daily living. In summary, this is a case of a 58-year-old lady, a known case of CA cervix treated in 2005, now presented with moderate pain over her right hip with restricted mobility and tingling sensation over her right lower limb. So the discussion points are first, of course, pain management. That is scoring, pain score, evaluation, and then subsequent management and treatment of the pain. Second is a concept of total pain, and the third is the psychosocial effect and economic burden of pain. Thank you.
Thank you, Dr. Sharon. I'll wait for a few minutes for others to respond, to add on to what they feel should be done for this patient. Either you can unmute yourself or we'll wait for the chat to come up. Dr. Sharon, can you just tell me the first discussion point? What do you mean by like pain score evaluation and treatment? You want to discuss about it, or what are you asking there?
No, yeah. So what I just wanted to highlight was it's good to have okay, the first point here is the pain score. So we need, if always, it's good to have an objective measurement of the pain. So in her prior to the treatment, her pain score, I mean, was 7 to 8, and after the disease specific treatment as well as the analgesics, her pain had considerably reduced. So I just wanted to highlight that. And also, as we had learned in the first class, in the first and second class, we always have to evaluate the cause of the pain and then treat it accordingly. And treatment also highlighting disease-specific treatment being very important. In the meantime, we do start on symptomatic management using the WHO step ladder, but the disease-specific management in her really went a long way in controlling the pain.
Thank you,
Yeah.
Dr. Sharon. There are a few questions in the why there was multiple medications instead of strong opioid, because pain scale of 8. So there
Yes,
are
yes.
this
No, for me, yes. It is mainly because we don't have that easy and access to tab morphine. That is why. I mean, we have a supply as of now. Like for example, we may have at that point, at being a COVID time, it was very difficult for us to procure morphine. So that is why I tried to make do with the tramadol.
Got it. Dr. Muhammad is telling excellent presentation, review of pain assessment and treatment according to the ladder. Yeah. Is it neuropathic pain is one question Dr. Haripriya has asked. Is it was it a neuropathic pain?
Yes, I think it is a neuropathic pain because of the presence of burning and tingling sensation. The location of the lesion also, it can compress the the site of exit of the nerves or the nerves. So yes, it is a neuropathic pain.
Ma'am, I would like to ask you about the management. There is a suggestion by Dr. Haripriya to add gabapentin, and would like to hear from you what you think about it.
Yeah, I think so, that it is a neuropathic pain, and that typically, that tingling and burning sensation. So we definitely have to add anticonvulsant or an antidepressant, or even both. Both can be added. And the good thing is that the pain has decreased with the treatment, and the pain score has come to more tolerable levels, but we need to treat the neuropathic component. That's important.
Madam, can I ask you a question?
Yes, sir. Please go ahead, sir.
Madam, you mentioned about the analgesic effect of antidepressant related to the antidepressant effect. I got confused in that statement.
The analgesic effect occurs at much lower doses of the antidepressant. For example, tryptomer that we are giving, or amitriptyline, we are giving in pain. We start off with 10 milligrams. And then after 1 week, we go up to 25 and 50. Whereas the antidepressant doses of amitriptyline are much higher. They may be 50 to 100. And they occur also at much the effect also is, this occurs earlier. The analgesic effect occurs much earlier than the antidepressant effect.
Okay, so that means the dose can be reduced considerably.
Very much, very much. Like amitriptyline, we start with 10 milligrams, which is nothing for the treatment of depression.
Yeah. Okay, thank you. And one more last question. Nowadays, we see people giving methylprednisolone for patients who come with fractures, paraplegias, etc.
Yes.
For early and prednisolone. What's your take?
Yes. When when we are expecting.
Infusions.
Pardon?
Sorry, sir, we didn't hear the last part.
Methylprednisolone, generally they are giving us. Yes, madam. Methylprednisolone, they are giving us infusions. What is your take on that comparison of both these drugs?
When you are when there is a patient with acute spinal cord injury, or even during during operation, there is suspected injury to the brain or any neurons in the brain, then we do give methylprednisolone as a bolus dose followed by infusion. That is recommended. How effective it is not known, but it is being followed. We give a bolus followed by the infusion. For that, we give methylprednisolone. Yeah, you're right.
So the same rule can be applied in spinal compressions in malignancy patients, madam?
No.
And fractures? No. Not.
Because for this, the compression, the nerve compression pain it's not that's for acute spinal cord injury.
Okay, madam. Okay, fine. Thank you, madam.
Dr. Yan has discussed the drivers of anxiety, prognosis and implications for family or her care. I think that's a response to your discussion point, especially the psychosocial effect and the concept of total pain. And I think it's important to understand what creates the anxiety in her, and maybe to have a discussion on the prognosis and other issues with the family. And just
concern, actually she has been cured from one type of cancer. She has got another, which is also limited. It is not metastasized. It has responded to treatment. So we have to put all these points forward and encourage her that, this is something that can be easily controlled. I mean, that kind of positive things can be told to her, that her fears are may not be really, unfounded almost, because it since her pain has come down and it is maybe stage 1, right? Is it stage 1?
No, actually, ma'am, it was not. It's like a metastatic cancer, because it's not the primary. It's not the pelvic bone. This is a squamous cell carcinoma, and beyond that, we cannot. It may have been a secondary malignancy after the treatment of the first. She had received pelvic radiation the first time. This may be a second malignancy. That is what that was our working theory, because we could not find any other primary malignancy until now. There's no sign of any primary of the primary, but it is a metastatic CA, so it's there to stay, but definitely it's better symptomatically than before. It's not progressed. Yeah,
nevertheless we can still give her a lot of positive.
Yes.
Ma'am, there are two questions, like same question by two people. How to choose the preferred first anticonvulsant or antidepressant, like which one to go ahead, or which is a preferred first choice?
I would, it all depends upon even the patient, whether the patient has got other, for example, if a patient has sciatica, the patient has got shooting pain going down the leg, but the patient is also complaining of dysesthesias. You see, many people tell me that when I put my leg on the ground, I feel I'm putting it on a cushion, or I'm walking on a mattress. Those are dysesthesias, So dysesthesias can respond better to antidepressants as compared to anticonvulsants. Whereas the pure pain is more responsive to anticonvulsants and antidepressants, but you have to choose between the two. But there is accompanying dysesthesias like abnormal sensations or allodynia or hyperalgesia, then maybe we can add an antidepressant. And also if the patient is having less sleep and anxiety, again, you would prefer an antidepressant. So you have to take it in toto, I mean, all the symptoms and signs we should put together and then decide what to do. If it's pure pain, without any dysesthesia, without anxiety, depression, then maybe anticonvulsant is good.
Thank you, ma'am. I think that doubt is cleared. Are there any other questions from Dr. Sharon? Were your queries answered, or is there anything else that you would want to ask, madam, before we wind up today's session?
No, I think that's all from my side. Thank you.
Thank you. Thank you, Dr. Sharon, for wonderful presentation. You have covered all the details and we could get a very good understanding about, even though we have not seen the patient, so it was very clear. Thank you for bringing in all the details in the presentation. Thank you all other participants for interacting through the chat and asking the questions and utilizing the time in clarifying your questions with Dr. Mary Abraham. And thank you, ma'am, for coming again for the wonderful session and encouraging all the discussions and learnings.
Thank you, Dr. Mary. As usual, very excellent and informative session. Thank you for joining us. We do know your busy schedule and still you find out time for our participants. It is, we are really grateful to you for that. Thank you so much. And thank you participants for joining in. And please don't forget to leave your feedbacks because end of the day, it is what helps us to improve ourselves. And with the promise that in the next session, we'll be meeting you with another equally apt faculty. This is Sri Priya, along with Dr. Mary Abraham and Dr. Sridevi Warrior, signing off from the Tips Eco Hub. See you in the next session. Till then, everyone take care. Bye-bye.
Thank you. Thank you.